in the United States. There's currently no vaccine to prevent COVID.
To this day one of Optimal Health Beyond COVID. In our second interview, we have Dr. Rob Karras. He is going to be sharing with us protocols that he has used and protocols that you can also use during this time. Welcome, Dr. Rob Karras. Thank you for being here.
Thanks for having me. Thanks a lot.
Okay. Well, as we jump in, I would like for Dr. Rob to just share with us a little bit what you feel. You can talk a little bit about your practice and what you feel has prepared you for this time that we have been engaging in these last 2 years.
Okay. Well, I'm a family practice doctor trained from Indiana University. But after residency in family practice, I moonlighted a lot and liked emergency medicine. And then after residency, I went straight to emergency medicine and started working in a busy ER. And I did that for about 10 years. I was the medical director of a couple different ERs. And so that was a good experience. But once I started having kids and the 12-hour shifts, the night shifts, I got tired of that. Then I went back into urgent care and family practice. I opened up a clinic in 2008 down here in Arkansas. We're in Northwest Arkansas, Walmart headquarters, University of Arkansas, Razorback headquarters, or where we are. And then, so opened up in 2008, my first urgent care. Then opened up another one about 2012, about 20 miles apart. And so we've had those two going since then. And then for the last 6 years, I've also been the medical director and run the healthcare for the state's second largest county jail, which is Washington County Detention Center. So we started out doing mainly urgent care, but then we evolved into doing urgent care and primary care. So we're a hybrid of both urgent care and family practice. I have two other full-time physicians working with me, and then also have 6 advanced practitioners, 2 physician assistants and 4 nurse practitioners that run our clinics. We probably see 50 to 60,000 patients a year. And we had this for Arkansas, we were at a good spot to really understand COVID. In Arkansas, it didn't hit Arkansas until about April. So we had a few months where we were all worried about it, reading up on it, studying it, but it just didn't come. And then the first places that it did come in Arkansas were the correctional facilities throughout the state where it really devastated them. Arkansas had the 5th highest amount of cases and deaths early on in compared to other states. And so having the second largest jail in the state and taking care of those folks, we were paying particular attention. We house anywhere from 700 to 800 inmates in our facility here in town. And so I have about 20 employees at each clinic and 20 employees out at the jail. And at the jail, we're there 24/7 and responsible for all their health care. So, that said, we took preventative measures initially at the jail. We started taking temperatures on everybody coming and going, asking questions, and we kept the temperatures down at the jail as much as we could because it showed that we let the cooler temperatures is where it seemed to hit first. It was hitting the meat packing plants here, starting to hit them the same time it hit the jails, or just afterwards. And so we kept our temperatures down. We checked people's temperatures. We stopped letting pass pencils, touching, sharing things, and all our PPE out at the jail. We did that. We also then at that time started giving vitamins to our inmates. When the inmates would first come in on intake, we would do 2 weeks of vitamin C, D, and zinc. We spent a lot of money on vitamins out at the jail. And we didn't get any in our jails, whereas it burned through the rest of the jails in Arkansas. But where we did first seeing it then, so we were watching it come. It was hitting the jails. We got scared. Took preventative measures and control measures out at our jail and didn't have any, none. And then the second place where it started hitting Arkansas about April was the meatpacking facilities. We have 3 very large poultry companies here in Northwest Arkansas: Tyson's, George's, and Simmons. They're all large, and that's where we started seeing our first cases in the clinics.
Do you think this is because of the proximity of the workers?
I think it was the temperature, and then the amount of research. Somehow it just was thriving there and really devastated the plants, or it really got heavily. Lots of people were getting sick, and my clinic in Lowell, I have a clinic in Lowell and a clinic in Fayetteville, Arkansas. And then Lowell, Arkansas was my initial clinic, and that clinic has 75% about Hispanic patients, primarily Mexican and El Salvadorian. And then also we do have some Marshallese. We have a large Marshallese community in Springdale, and they work at the poultry plants. And so all of a sudden, just like a light switch turned on, our parking lots filled up, and we started seeing really sick patients. And that's where we saw firsthand, wow, this COVID is bad. Initially, it was hard to believe that it was going to be bad when you just, my initial mistake, or the way that made my thinking off, was that if you look at China where it hit, there were 3,500 deaths. Well, if you take the number of Chinese people by the number of those deaths, and you do your little algebra to the United States, we should have had 750 or 800 deaths with the COVID, right? At least on the initial wave. And obviously that's not the case. It was much more devastating for whatever reason when it hit the States. So that's why I wasn't that concerned at first. I'm like, okay, well, we're ready. We can handle it. And then it came, and then, it's a virus. So from what I was reading, it's a virus. So viruses, you want to have your immune system strong. So that's why at the jail we started the vitamin C, D, and zinc. We all know those are helpful for viruses in your immune system, and they're basics, and there's no side effects. That's what we started with that. Whereas when we started seeing the sick folks at the poultry plants, there's a couple other medicines we added prescription-wise. From what I'd been reading, Singulair or Montelukast, an old asthma medication, seemed to maybe help with the COVID pneumonia. And so I knew that's been around. It's generic, it's very safe. We added that to our treatment from the start at the outbreak from the poultry plants. We also added doxycycline, which, for looking over the literature and stuff, it has some antiviral properties. If you research it with dengue fever, and there's now some COVID studies on doxy as well. And it's also an anti-inflammatory. We use it for acne, and so it helps with inflammation. We learned, or knew at the time, that the COVID caused a lot of inflammatory processes to get going. So we picked doxycycline, we picked Singulair, and then the 3 vitamins, and that was our treatment regimen at first. People were coming in. It was an unusual disease in the fact that people could have very low oxygen and not look very sick at all. They could have an oxygen in the 80s and be talking to you and not look sick.
Right.
So that was shocking and stunning. From there, what did we do? So in that first wave where the poultry plant workers, I was blogging as this COVID was coming on our Facebook page. You can follow it. From the start, I would blog and say, hey, we don't have any right now. We still don't have any, and things like that. But then all of a sudden we had a lot. And then as it got worse and worse, our hospitals here in Northwest Arkansas were coming to capacity. We were sending lots of patients to the hospital. We probably ended up having 30 or 40 patients be admitted to the hospitals, and we try to follow them daily with touching base with the physicians or the nurses in those hospitals. We had direct, I'm not affiliated with any of the hospitals, but we could call and do direct admission patients for a couple of the hospitals here. And so we would follow our patients in the hospital during that first wave in end of April and May and June. We had 6 patients die, and some of them didn't get any of our treatment. They came in so sick and looking so sick that we would admit them directly to the hospital, and they wouldn't get any of our treatments. But so that was the first wave. That died down some. The second wave started in Arkansas here, kind of with the college kids coming back in September of 2020. So when that came, they came back to school. The kids were all getting together. My office here, where I'm at now in Fayetteville, is about 2 blocks from the university. And some mornings we'd have 80 or 90 students lined up for testing before we even opened the doors. And so we got away with that. That way was great because the kids didn't get that sick, or the university students didn't get very sick. We didn't, from what I recall, I don't remember us having any losses or fatalities with that wave. And then it was October here in late 2020 or November, as it started hitting everybody in the community, like the whole community. And we got a big wave with that. It also came, it took that long. We didn't really get it in the jail till mid-October or November of 2020, which was we kept it out of our jail system a long time compared to all the other facilities. And so that was good. But then it hit the jail. And the way it's set up, I usually do half the week at my one office in Fayetteville, half the week at the other office in Lowell. And then we'll do, and then I'd go in the mornings for 45 minutes an hour at the jail and help there, where I have a full-time nurse practitioner that manages that. And so with the poultry plant outbreak, that primarily hitting my Lowell clinic, I stayed at Lowell the whole week. We would stay open 7 days a week. We're usually only open 6 days a week, but we would open up more. So I stayed in Lowell. Then with the college outbreak, I stayed in Fayetteville. And then with the community outbreak, where it got heavy at the jail, I was at the jail full time for a while. So then this is just kind of the evolution of how it hit Arkansas and how we did our protocols. And so, like everybody, our protocols were adjusting as we'd learn more studies would come out. The biggest change from that, what I call our mid D3 100,000 protocol, is that the first thing we added were steroids. I think it was probably September, October 2020, when the studies out of England showed that steroids were helpful in this process. So we started using steroids at that time. And then we added ivermectin in mid-October. I had my first patient come in where I added ivermectin. I have a friend from Indiana University that I went to med school with. It's an anesthesiologist, Dr. Lance Hoover, who really read up, and all he did was read on COVID and understood COVID way better than I did, at least the pathophysiology of it and such. And so he said, I think ivermectin's looking like it's working. They're using it in a lot of places. And I had a Hispanic patient come in through Old Clinic that was very sick. And I gave him a dose of ivermectin, went over to the pharmacy, gave it to him, picked it up for him, gave it to him as we started an IV on him. Also, early on with that initial wave, when people were very sick as well, I would also use IV vitamin C, which I've used for a few years for people when they get bad viruses. Some studies show it's got a lot of antiviral properties, but you can only take so much oral vitamin C before you get loose stools or diarrhea. And so with that first wave at the poultry plants, there were probably a handful of people, a few of my employees, when they got it, I used IV vitamin C, and then a few of the sick patients, I used IV vitamin C on it. And initially I would do a dose of 25,000 milligrams in a liter bag, and that's what we'd give. And so that's kind of where we were at. Then in October, we added ivermectin. Shortly after we started using ivermectin, a patient said, hey, have you seen the FLCCC website or heard of those people? And I hadn't. So I looked at their website. I looked up Dr. Paul Merrick, watched some of his YouTube educational videos on COVID, and they were very helpful in understanding how COVID works, right? You get sick, it's not much, a sore throat, cough, or cold. Then about a week later, it starts attacking the lungs, all the hyperimmune response or the immune pathology phase where it starts attacking the lungs. And then clinically, your oxygen starts dropping. So, it's interesting when I looked at their site that their protocols were pretty similar to ours, or we were using a lot of the similar medicines. They were using a few more, we were using some they weren't. One of the things they were using quercetin, and we didn't use it, but I was using the Montelukast or Singulair, and they weren't. At talking with the pharmacist, he said, that there are similar effects. That the quercetin seems to look similar to the effects of the Singulair Montelukast. I emailed Dr. Merrick and talked to him and said, hey, I'm just talking. What do you think about this? And he said, oh, I've heard of it, but I haven't read any of the literature on it. And that was my first correspondence, I think, with Dr. Merrick, who I've corresponded with 20 or 30 times, and talked to 3 or 4 times on the phone. And he's very supportive and helpful, and on what we did. So we had those first few waves. The first wave of the poultry plant, we lost 6 patients, but then we were doing great. The college wave, we didn't lose anybody. And then we also, during the community wave, we had tweaked our protocols with the steroids, with the ivermectin, with the IV vitamin C, bigger doses about in January of vitamin D3. I like watching some, not every day, but frequently I would watch Dr. John Campbell, who has gotten over 2 million followers now. He's a nurse, professor of nursing in England, and he just presented data after data studies, very, very just information.
Yes.
And in I believe it was January 2021 or maybe February 2021, he had a nice article on vitamin D3. A couple of studies. I think one was in Spain and one was in India, and there was inpatient using mega doses of vitamin D3, and it had decreased the mortality rate with those patients. And at that point, we started going to higher dose vitamin D3. Initially, our vitamin D was 5,000 3 times a day, but we've gone up, and now our initial protocol has you getting vitamin D3, 100,000 units a day for 3 days. If you come in very sick, get our C-Caleb protocol, we'll give you 200 to 300,000 in one dose. And people tolerate it well. And then at the jail, instead of 2 weeks of vitamins, we do just a large dose, a one-time dose of vitamin D, 100,000 units a day. The first day they get there, that's where we went to, so that's where we got with our specific protocols. I'm just looking them over again too. After right now what we use, I guess we use Monolukast. That's the M in the MID3. The ivermectin is the I, the doxycycline is the D, and then the D3 is the D3, and it's 100,000 units. We also would use vitamin C, 1,000 milligrams 3 times a day, zinc, 100 milligrams daily, melatonin, 10 milligrams a night, Pepsid. We picked off of the FLCC protocols. They were using that inpatient in the hospital. And we do that. We do aspirin as well, or pretty early on. We do a full aspirin for 2 weeks if it's an older adult, probably 35 or 40 or older, or if they got really sick with it. We did also have monoclonal antibody therapy available when it became available through the clinics. We gave hundreds of those when we had them.
You don't have them anymore?
No, those with the new Omicron starting in January, the first 2 monoclonals didn't seem to work, there was a third one that did seem to work, the Sodalol, I believe. We didn't have access to that one. We only had access to the first 2. I can't remember their names offhand. And then also to point out, we also were a study center. I was the primary investigator for a large monoclonal antibody study, Adagio 20. And it was a study where they had tweaked the half-life of the monoclonal antibody to where it would be 5 times longer than what it was. And it was kind of like a non-vaccine vaccine. You would get in it. And we had the most enrollees in the country for this study. And about a month ago, it got presented to the FDA for EAU authorization, but it really decreased patients' likelihood of getting COVID, and it helped if they did get COVID while that they had the antibody. So that antibody would last in your system for about a year, and so they're awaiting word right now on whether or not that's going to get FDA EAU approval. So we were also we had the most enrollees in the country for that study, and it looked like a very safe study and a good study. So it's kind of like a non-vaccine vaccine. Right. You just get the shot antibodies, they float around in your system for a year. And if you get the disease, then they're ready to ramp up and start fighting the disease. So we were doing that as well. And then the next thing we can talk about is like the Delta wave. The Delta wave hit Arkansas in July. It hit Southwest Missouri first, but then it came to Northwest Arkansas. So we were right on the front of that. I'd heard, and a lot of people said, oh, it's more deadly, it's more fatal. And so for the first week or two, when we had some cases at the jail, we had I'm on our jail protocols. Everybody did well. I did an interview with the local news station when the Delta was hitting here, because everybody, there was a lot of panic with that, or a lot of fear with it. And my interview, I'm like, no, we've had some cases out of the jail. We've had some cases here. Everybody seems to be doing well. We haven't had anybody in the hospital with it, and very confident and comfortable, and wasn't in panic mode. And they didn't play any of that video on the newscaster for their news report. And but that was a Friday. I did that interview, and that Saturday morning on the Facebook page, I had a patient's wife Facebook our work page and say, hey, my husband is in the hospital. He's intubated. He's doing very poorly. They're trying to send him to the med center and get ECMO. And is there anything you can do? And so I looked him up, and we had seen him the Friday before. So that was a Saturday, not the Friday where I did the interview, but the Friday before. And we had seen him, and he was on day 7 of his illness. And he was a 29-year-old young man, pretty healthy, just, real healthy, just a little overweight, no meds, no diabetes, worked outside. And he was doing terrible, and he was intubated. But he had seen us on day 7 on the Friday before. We had given him a shot of steroids, and we didn't do any IV vitamin C. And we started him on ivermectin and our mid-D3 protocols. It was one of the nurse practitioners had seen him, started him on that. He got 1 day of his meds, and then Saturday he was feeling sicker and got admitted to the hospital. And unfortunately, they didn't continue any of his meds we had him started on. And so the long and short was he got sicker and sicker, and they used their regular meds, their FDA protocols and their hospital protocols, and he passed away. And so so that was a Saturday, and then that Monday, just ramped up. The Delta hit, and it ramped up, and we started seeing sicker patients, and one of them was my friend that I'd gone to church with, about my age, and his kids were about my kid's age. He had some risk factors with his BMI. And so we did IV vitamin C on him 1 day, gave him a shot of steroids, came back the next day, did another dose of IV vitamin C on him, gave him some ivermectin that I told him to take this into the hospital, and you take this for the next 3 days. And he was very high risk. He was in his 40s, I think 40s, and he got intubated, and his BMI was very high, but he was only 10 days on the vent. Then he went to the rehab hospital for about a month, and he's home with his daughters. I saw him at a basketball game about 2 months ago. Gave me the biggest hug in the world, and it was great. But so from that young man, the 29-year-old dying, and me seeing it firsthand, we started seeing tons of sick Delta wave. And for about 6 months straight, I worked every day. And And then from the Delta wave, we went on into the Omicron wave, which is bad here too. And also from that, during that wave, we've probably had we called it the C. Caleb protocol. I talked with the patient's wife. His name was Caleb. We named it the C. Caleb protocol, which was the high dose vitamin C and the big dose of steroids plus all our other meds. And so we started doing that on anybody. And like a good clinical indicator, which not a lot of people talk about, is where you have where your oxygen level. Right? You get that pulse oximeter. I wish I had one here. I don't see any laying around, but you put it on your finger. And a normal, healthy adult that doesn't have emphysema, that's not very old, that's not really old, should have 97, 98, 99 as their oxygen level, 96 maybe too. So if you're going below 96, something's gone. You can put that oxygen checker on, go run a mile, and it's not going to go below 96. You can hold your breath for 5 minutes. You're not going to drop that oxygen pulse oximeter below 96. So if you're getting that dropping, then you might not show up on x-ray that you have COVID pneumonia, but you've got COVID pneumonia clinically, in my opinion.
Yes.
You're starting to get major damage. You're getting the second phase, the pathoimmunology phase, or the hyperimmune response phase, where your lungs are getting attacked and you are getting a serious infection. So the oxygen checker is a great way to know whether or not you're getting very sick. And if you are, that's when we would bump up. When you start dropping your sats, that's when we go from our mid D3 100,000 to our C. Caleb protocol. So we ended up doing 50, we doubled it. We did 50,000 on day 1 of IV vitamin C. We'd leave the IV in, send them home, steroids, all their other meds, come back the next day, we'd give them another 50,000 milligrams of IV vitamin C. Sometimes the people, we would do it in 50,000 in 1 liter. A lot of times, if they were real sick, we'd do it 25,000 in a liter and do 2 liters of fluids. Fluids helped a lot as well. I think people were so dehydrated that they would need that much fluids because they wouldn't be sick or eating. And these people would be needing this C. Caleb protocol. We even had what we called it, initially we called it the AG sign. Like you have different abbreviations for medical terms and conditions, named after people. But our first patient with we call it the AG sign. It would be the male, usually the male, especially with Delta. The wife would bring in the husband, and he would be in the passenger seat, kicked all the way back, looking very gray and pale, looking like death, like they were very ill. And we'd call that the AG sign because the first person we saw like that was a patient whose initials were AG. When we sent him directly to the hospital, and he was intubated for about 2 to 3 weeks, but he lived and he still comes in. We're always so excited when we see him. But so we named it the AG sign, but then we've later changed it to the chauffeur sign. So these people would be driving up, and their wife or their girlfriend would be driving them up, and it would be the man. That's just the male stay home. You don't feel that bad. That's why it's a very insidious disease. When your oxygen starts dropping, you don't feel that bad.
That's what happened to me. That's what happened to me. I had COVID pneumonia, and I didn't know it. I was chauffeured.
Mm-hmm. Unusual female chauffeur sign. So we would get these, and so with the Delta wave, it really hit the men harder, and then also that's by the time the vaccine had been out, correct? And so ends up, now that it's all played out of about 1,000 of the C. Caleb protocols we did, 998 of those were done on patients that had no vaccine. Yes. 2 of the people had vaccines. One was a diabetic that was vaccinated that ended up passing away. And the other was a guy that got better, but he was unvaccinated, or he was vaccinated, an older man. So that's when I started promoting the vaccine more especially to adults. I've never promoted the vaccine or pushed the vaccine on young folks. But it was, in my opinion, in my experience, it was very helpful and saved a lot of lives. The vaccine did. What else did we do in that time period? So yeah, we were busy, full speed, seeing. And then we ended up getting in the news. Some political person in town However, it didn't like that we were using ivermectin on inmates at the jail. And the sheriff called me and said, "Hey, can you talk to this lady? She's like a councilwoman. Will you talk to her?" So I talked to her. She was all upset and irate that we were using ivermectin. And I tried to explain, like, "Hey, we've had this many cases." And here's another, I guess, a feather in our cap, or something that I will say without really bragging, but it's just statistics. We've had over 1,200 cases out at our Washington County Detention Center, the jail, and we've had 0 deaths out there, 0 intubations. We admitted 1 patient for 2 days, an older gentleman in his 70s that refused most of his meds, got admitted for 2 days, and then was released. So over 1,200 cases with 0 deaths. If you look at the case fatality rate with COVID early on in the states, in Arkansas, it's about 1.55. Currently, last I checked, it was about 1.33. So 1,000, you should have 15 dead inmates. And if you look at the initial outbreak at the largest correctional facility in the state, early on, one of the correctional facilities had about 1,200 cases, and they had 11 deaths in just the first outbreak.
Wow.
So we had 0 deaths. So it's not like the old movie Brubaker, where we were burying them out in the field,
Right.
the Robert Redford movie in the 70s, which were Arkansas prisons, by the way, that movie was based on. Yeah, everybody's healthy and accounted for. And so the sheriff said, "Call her." I call her. She was not nice. And I was trying to tell her how it was helpful and how it seemed to work. And it blew up in the news. And now we have lawsuits and state medical board meetings in regards to that. But I'm very proud of our record out there, and I'm proud of our record. We've had over 11,000 cases in the clinic, or we've cared for over 11,000 cases if you reviewed our EMR and look at diagnosis for COVID-like illness. And we've had 27 patients pass away, unfortunately. So that's 27 out of over 11,000. And also it's not apples to apples, because we were in the 3-state area. We would get very sick people coming to us that had COVID for a week. Their oxygen are in the 80s and low 90s, and we do our CKLA protocol on them. So we'd get all those very sick patients, which had the high mortality rate. And so at least 1,000 of those were already severely ill and didn't get and at the jail, the difference, I think, is at the jail, everybody, we test early, we test all the time, any symptoms, we test them, and we treat early. And that's why our record at the jail is perfect. Whereas outpatient, where people are just coming in too sick to us, unfortunately, they waited too long at home. And and that's twofold. I think 2 reasons why that happens is because, one, what you hear on the news and see on the news and see from the government, see from the FDA, see from the CDC, there's no treatment, there's no treatment, there's no treatment. The Hippocratic oath.
I wasn't
Sorry?
prepared. That's what happened.
Right. Yeah, you didn't know. That's what you read.
To get treatment, they were like, "There's no treatment."
Yeah, you go to the emergency room, like our Caleb patient that passed away. They sent him home. He got diagnosed here, sent him home. And then come. They would literally tell people, "Come back when your lips are blue." All right.
Exactly.
And then when we got overwhelmed with the Delta wave and the hospitals were very full again, it'd be like, "Okay, your lips are blue, but go home on this oxygen and come home now on home oxygen when your lips are bluer." And so and that's how we developed and tweaked our CKLA protocols as well. As basically, we started taking care of patients that had been in the hospital. They would have their SATs in the 70s at home. They'd be on home oxygen in the 80s, and they'd stay at home because they don't want to go to the hospital. They said, "I'm not going." They patients tell us, "I'm not going to the hospital." So we'd arrange for home oxygen. We got the home oxygen companies give us oxygen machines in our clinic and tanks, and we'd send patients home on it. And we'd have them follow up every day and call them. And so we took care of lots of patients that were that sick. And that's why we adjusted our protocols to some that include some of the FLCC in-hospital protocols. We'd use some of the medicines they were using in the hospital on our protocols as outpatients, because that's where they were being treated then. And then also, there were there's only a few hospitals nationwide that were using those FLCC inpatient protocols. Dr. Merrick's hospital, Dr. Varick or Veron down in Houston. I tried sending 2 or 3 patients down to Houston. I never did get them transferred. Some of them got too sick. One of them passed away. And then the other ones that they just wouldn't. They said it wasn't. They wouldn't send them because it wasn't a step up in care. To me, it was, but and so yeah, I'm not sure what the Latin word is for it, but yeah, the hospitals don't like me. The hospital physicians or hospitals aren't. They didn't like our treatment protocols. Um,
That's very sad, but I do just want to acknowledge, first of all, your bravery, your courage, and for standing up for the people, for the inmates. And we need more doctors like you. And so I thank you. I thank you for that,
Thanks.
for
Yeah,
standing in that
we
gap.
had the we had the medical board meeting a while back, and I told them like, hey, we treated my family, my in-laws, my mom, my stepdad, my kids, our patients, and the inmates all the same. We treated them the same. We weren't treating anybody different, and we were transparent throughout, telling everybody on Facebook, these are our protocols. This is what we're using. You guys can take these at home, the vitamins at home, and then even with our protocols, I would tell people because we had a pretty big Facebook following, like anywhere from 10 to 20,000 people, or 5 to 20,000 people reading the post. But when we took a week off because we were exhausted of Christmas to New Year's of 2021, and we've done worked 6 months straight with the bad Delta wave here in Arkansas. And we told people, hey, you could probably go to any urgent care ER, and you can probably beg your physician to give you all our meds, except the only one that people don't give or wouldn't give would be the ivermectin. But Singular, the old asthma drug, they should give. The doxycycline they should be able to give, and the steroids they should be willing to give. And so that's good. And then actually, one of the local hospitals did end up calling it the CARES protocol, send patients home on that, but not the ivermectin. So that's good. And I think that was helpful too.
Well, that is wonderful. So as we're wrapping up, would you like to explain the gift that you want to leave the audience?
Um, you know, uh, I would say, there's the gift. I mean, we felt good about the job we did. We took care of a lot of people, and in my opinion, we saved hundreds of lives. And that's why I'm interested in getting, especially our CCALIP protocol out there, with the high dose, mega dose IV vitamin C, 50,000 for 2 days in a row, with the big dose of methylprednisolone, 160 milligrams IM. And then the doxycycline, I think, is helpful. The Singular is helpful. We also did discuss and had with all our providers, we had a Zoom conference call with the professor out of St. Louis University who did the initial study on Luvox or fluvoxamine that decreases mortality with the COVID. She did a great job. She got a $20,000 grant or $40,000 grant from her school, studied 180 patients early on, and noticed a statistical significant difference between this, and then got a little more funding elsewhere. Now some other studies did. Why there weren't hundreds of studies going on all throughout the United States with different clinics or different things, but they didn't want to study any of the old medicines. They wanted to study all these new medicines that would time after time not work.
I believe that there's some things that are very evident without having to mention them, right? So
Right, yeah, it's obvious, right? And so
unfortunately, it's
but
very
in my clinic where we keep growing, we see new patients every day. I think there's a lot of distrust among most folks, especially here in Arkansas, where they don't trust their hospitals, they don't trust their physicians, and I'm needing to hire another physician already, and I just hired one 2 months ago. And so, it looked bad in the press, it looked bad
they'll make you look bad.
online, but we have lots of patients coming to us. We have a great work environment. It's fun, it's enjoyable. We were exhausted. It's going to take us 6 months to probably recoup and get back to our normal baseline stress. But I'm super proud of all of my coworkers and all of our practitioners. They worked really hard. They all worked super hard and did a great job. And we all got COVID multiple times. I've had it 3 times, probably 4. I just didn't check the last time.
You just didn't stop.
Huh?
You just didn't stop.
Yeah, we didn't stop, and we kept going, and we kept everybody, all our coworkers safe, all their family members safe,
Beautiful.
all our county employees that work out in the jail safe, and
That's wonderful.
yeah, and so it was great. It was a great experience, and that's what I think medicine's about. And we practice medicine. Again, it's not the Hippocratic Oath is to do no harm, and it's not to do nothing. And they sit there, and there's a few articles that come out where ivermectin, and I even said, like, ivermectin, it was a great medicine. It's a great medicine. It was helpful, very helpful for COVID. But there's a lot of other medicines we use, like, depending where I'm at in the process of prevention. I think ivermectin was great early on, maybe not so much for Omicron and for Delta, but it was great for prevention. And I used it. I took it every week for a year. And then but we have other meds. But with all the studies, ivermectin's been studied the most. There's 81 studies out of 21 different countries, or 23 different countries from 22 different groups of people. The majority of those showing benefit with ivermectin. 0 of those studies showing that it hurts. Yes. So there's no harm done with it. And to talk to these other physicians that were in the hospital that were using medicines that had clearly started to show there was no benefit in mortality at all. No benefit and no gain, and maybe a little bit of a negative side to them. And they would still use those medicines, but they wouldn't try these other older, safer generic medications.
Right. So what are your final thoughts for our audience as we're wrapping?
The final thoughts are: take responsibility for your own health. Right? We said that from the start. Be healthy, take your supplements, get outside in the sun where your body makes your own vitamin D. I would say a big difference too is our huge dose on the vitamin D, mega doses. You want vitamin D normal levels in America when we check them are 30 to 100. Most people are in the 20s, maybe low 30s. I want people to be in the 70 to 100. It doesn't have to be fancy, expensive vitamin D. Just start taking. It's probably, depending on how much you weigh, 5,000 to 10,000 units a day, maybe more in the winter time. If you're heavy, it'll be a little more. But check that level and get it to 60 or 70. During this process, I was talking with my friend, the pharmacist that I rent from in one of my clinics, and he said, in pharmacy school, they call vitamin D the master hormone. And and I would compare a lot of times the medicines we were using, what we would do with heart attacks. I did ER medicine for over 10 years. There's about 8 to 10 medicines that dropped your mortality with heart attacks. The one that, what medicine drops your mortality the most with heart attacks?
Which?
Aspirin. So 50% of the drop in mortality comes from aspirin alone, right? If we were trying to approve aspirin through the FDA today, it wouldn't get approved. To me, that's what vitamin D is like that. That was the key factor, and that's the cheapest, easiest, safest way to try to. That would have dropped mortality tremendously, I think.
That's beautiful. That's beautiful.
So, and so you got to be outside. You got to be active. You got to be able to get your heart rate up. We got to quit eating so much sugar, corn syrup, and we got to get our obesity levels down in this country.
Definitely. Well, Dr. Rob Karras, we thank you so much for spending this time with us. As you can see, he is in the middle of his workday. He's made time for us and to explain the protocols that I know that are beneficial for us now as we are sort of in a lull and we don't really know what could be around the corner. But we celebrate heroes like you there in Arkansas, taking care of your people and on all levels. And we just pray God's blessing over you. Thank you so much for joining us today.
Thanks for having me.
so I was like, sure, I'd love to go to the front lines in New York, and I bought a ticket and I was ready to go. And then the next day they're like, oh, we don't need your help anymore. And what happened at that point was all the hospital jobs that I've been doing for 10 years suddenly disappeared overnight. Like for the next year and a half, there wasn't anyone looking for a hospital doctor because there were no patients going to the hospital.